Why is it so difficult for us to accept a version of ourselves that we don't see ourselves to be? Um, I'll give you an example about myself. I always saw myself as a very punctual person. I'm always on time, and I really prided myself about that. And I was for a huge part of my life. I was always on time, if not before time. But things change. Something over the years has probably ground me down a bit. I take longer to get ready. Um, and like today, for example, I was making a cake and I got late. I was thinking in my head that I cannot give this as an excuse that, oh, I'm busy and it's too cold, so the butter is frozen, and that is why I'm late today. And I kept telling myself, you're not late, you're just very busy. You're not late, you're very busy. And I had to accept at one point that, yes, I am late and I am not as punctual as what I believe myself to be. And I see this all around me happening all the time, that you have a certain version of yourself, and that's the version that makes you feel good about yourself. So anyone saying that you're anything else brings out a lot of defense or insecurity or denial. And unfortunately, this also happened with a friend of mine who was married to somebody who had extremely poor sperm quality. And despite the doctor saying repeatedly the problem is with you and not with her, he couldn't imagine himself to be anything but virile and, manly. And I was part of some of these conversations, and unfortunately, the marriage ended as a result of this conflict. But it was something that really opened my eyes to the idea of male infertility. This is Sonali Acharji, and you are listening to Health Wealth, a podcast that hopes to leave you feeling much more informed about your well being, but also very enthusiastic to take the right steps for your health. Um, there's a lot of misinformation about male reproductive health because I suppose we don't really talk about it. There's no Male Reproductive Health World Day. And I remember asking a friend before this particular episode, and he said, why do you even need to do this? It's not in the news, it's not trending, there's no hashtag about it. And I said, well, I suppose it is still informative because, a man's reproductive system is also part of his body. And then I asked him a bit about it, and I said, what do you know about your reproductive system? Um, And he said, no, let's Google about it. And when I did, all we found were science websites, a lot of strange medicines, and sources of snake venom and bull penis, none of which were something we could use. And that's when I also asked him, and I said, why is it so difficult for you to talk about male infertility? And he said, I know it sounds like something that's been said many times, but I take it as a sign of weakness. And it's very difficult to accept that I'm not doing what I'm supposed to do as a man, that I cannot impregnate a woman. And, so it's easier for me to go and pretend if, he said I'm ever diagnosed with infertility, I would just pretend that, it's wrong. The doctor is wrong, the healthcare system is wrong, and everyone's out to milk me for my money, or in this case, my manhood. And so I'm really, really thankful that we are joined today by Dr. Rajeev Kumar, who is a professor of urology at AIIMS New Delhi. And because I do think this is one of the least talked about subjects, and I'm just very, very happy that he's here to educate us on it. Hello, sir.
Thank you. Thank you for asking me to be here. It's a pleasure to be here.
Thank you so much. Before we even get to infertility, I'd just like to know a little bit about the male reproductive system. What does it comprise of?
Right. So before I describe you that, let me just take you up on that little introduction that you just gave. I finished our male infertility clinic just a little while before coming and joining you for this podcast. We run this clinic at the moment once a week. We've been doing it for over 10 years. And considering the restrictions we need to place on the number of people we can see around patients, we still see patients in each clinic every week, which means we're seeing about 2,500 patient visits a year. And this is the extent of infertility that we're talking about. And when you say men don't want to get treated and don't want it recognized that it exists, it's obviously a fact. This is just to put a number on what we do here. And we just put the tip of the iceberg, of course. We don't represent the entire numbers that exist, but it's massive. So when you talk about the reproductive system in the male, divided into two parts, or divided into three parts, actually, that's the easier way of looking at it. The first is the actual factory, the production house. That's the testes in the men. So you have two tests, the men have two testes. That's where the production happens. And the production is of sperms. That is the meat or the structure that is required for producing an ovum or an egg, producing an egg. So the testes is where sperms are produced. Then we talk about the delivery system and the control systems. So the delivery system is after the sperms are produced in the testes, they travel through narrow tubes that are called the vas deferens, which join the urinary passage of the urethra, and then they pass up through the penis. Therefore, you have a common exit pathway, both for urine, which comes from the urinary bladder, and for the sperms, which are coming from the testes. So you have the production, like the factory, and the delivery system. And then you have the control. The control is hormonal. That is primarily from the brain, where you have the principal production of the hormones, which then control hormones within the testes itself. The testes also produces hormones that regulate the testicular function, but they're under the control of the brain. So it's the summary of these three systems which gets to produce those sperms and to deliver them.
And can we just talk a little bit about sperm in in terms of its health and well-being? So, ideal sperm, what is it like in terms of, say, count or morphology or its mobility? What's ideal sperm supposed to be?
Great question. And it's a great question, particularly in the context of our country. And let me explain what I mean by that. Uh, Sperm counts, defining normal sperm counts is a very difficult task. And why is it so difficult? It's because at the end of the day, you need just one sperm to meet one egg and produce a child. Therefore, to say that somebody with anything more than one is theoretically potentially possible to produce a child.
Mhm.
However, when we look at what is normal, we look at what is defined by the WHO. That is what is defined as the reference standard worldwide. The WHO produces what are called WHO manuals on analysis of semen, and which gives you what are supposed to be normal counts. The definitions that the WHO uses has its advantages and disadvantages. The advantages, of course, is that you have a standard that you can refer to. The disadvantage is it really doesn't tell you what is normal and what is abnormal. All it tells you is that 95% of men have counts greater than this or have numbers greater than this, which
Mhm.
doesn't mean that the guys below it won't have a child. People below it may still have a child only, and people above that number may not have a child.
Mhm.
But we use that as a reference. It's important to
Mhm.
understand this because just because your numbers are lower than what WHO says is normal doesn't mean you can't have a child spontaneously. You still can. So, what are these numbers?
Mhm.
Again, these numbers keep changing, and unfortunately, WHO again keeps changing them every few years. We had a most recent one in 2021, and I'll give you ballpark figures because it's easier to remember. So, if a man's producing about 1.5 ml of an ejaculate, that's normal. 1.5 ml or higher is normal. If he has total sperms of greater than 40 million within that ejaculate, so I'm not looking at numbers per ml. You get two values in sperms. You get number per ml and you get total numbers. So theoretically, there is a number for both. If the number per ml is greater than 15, it's supposed to be okay. But the more valid number is actually the total number. If the total number is greater than 40 million, when you ejaculate, it's supposed to be okay. The third important parameter is how many of them are alive and moving. So
Mhm.
you have a 40 million sperms. How many of them are alive and moving? So the number there is again supposed to be about 40% of them. So if 40% of them are alive and moving well, you're okay. These are the three most important numbers. The fourth number, which is often given, is how many of them look normal. That's called morphology. How many of them look normal? There the number comes out to actually 4%. So if just 4% of them look normal, you're okay. So summary takeaway, 1.5 ml of the ejaculate, 40 million sperms in it, 20% of them are moving. These three are the most critical numbers. Morphology is a very difficult number to quantify, but 4% if you want to remember that. And again, the take home message,
Yeah.
don't look at the numbers alone. The numbers tell us when to start investigating a person, but they don't really say anybody below this can't have a kid on his own. He still can.
Right. So, what determines if you can or cannot have a kid then?
Right. So the first parameter, of course, that we evaluate in the male is these numbers. Because when you look at a male as a contributory partner in fertility, the first parameter you can actually evaluate is only the semen analysis. And that's the only objective parameter we currently have available. So if your numbers are above what I've defined as normal, the chances that you can have a spontaneous child, and remember when we talk of fertility, we divide it into two parts. Can you have it spontaneously without needing anybody's assistance? Versus do you need assistance? So if your numbers are above this, you're quite likely to be able to have it without needing assistance. Again, assuming the woman is normal, because we're looking at two partners who are contributing to it. So the discussion primarily revolves around the assumption that the woman is otherwise normal. So if your numbers are above this, we would wait before we investigated you further or treated you further because these numbers suggested likely to have it spontaneously. If the numbers were below this, that would be an indication to start evaluation and potentially treating if a cause were found. However, I am reiterating this with the risk of repeating myself. Just the numbers alone aren't enough. The numbers are things which trigger an evaluation or treatment. People with higher numbers like 100 million, 150 million, may still not be able to have a child. Whereas
Yeah.
guys with 5 million may be able to have a child spontaneously.
Yeah. So, in a lot of disorders or issues, it's good to diagnose early. So, in terms of male infertility or any issue with the male reproductive health, what are the sort of diagnostics available? When should a man do them? And, do they need to be done annually or just when you're going to conceive?
Okay. So there is no concept of screening for infertility. That is not recommended. And again, the reason for that is logical that we don't know what is normal. I mean, if I find your counts today to be 5 million, can I say you're not going to have a child? For all I know that your counts are 5 million today, you're 22 today, you get married at 24, your counts remain 5 million, but you have a child on your own. Therefore, should I start evaluating you and treating you at 24 because of 5? The answer is no. So when should we start evaluating? The classic recommendation is if you've been trying to have a child for a year and you fail to have a child for a year, that's the first trigger to start evaluating. So, infertility for the last 1 year, you've been attempting to have a child, unprotected intercourse for a year, and you haven't had a child. That's the first trigger. However, there are people who should be evaluated earlier. For example, people who've had chemotherapy, radiotherapy, previous treatments, previous injuries to the scrotum, they don't have a testes. A testis has been removed for some reason. They've had injuries to the scrotum. There are hernia surgeries. These are people where the risk of having a problem is higher. Therefore, you may consider having them evaluated earlier. Or if for some random reason a semen analysis was done and there were zero sperms. These are conditions where we would say you don't really need to wait for infertility for a year before you start evaluating. But for everybody else, if you don't fit into those categories, don't jump into a screening, don't start getting annual tests done. Wait till you've had an attempt for a year. If you failed, that's when we start treating you.
Right. And suppose in childhood or even later on in adulthood, if there's any injury to the groin area, it might feel better the next day, but does one still need to consult a doctor?
No, not really. Every injury doesn't need, I mean, injuries will be of various grades.
Like a
If
cricket
you've
ball,
been
because that seems to be the most
right,
common.
that's a common thing. Okay. So, and virtually every boy who's been on the field in India would have had a
Yes.
cricket injury at some point of time in his life.
Or an
If
angry
that,
girlfriend. That also happens.
okay,
These
okay,
things.
I won't go there. I'm just going to get cricket ball for now. So,
Yes.
if you had an injury and there was a swelling, the testes got swollen up. Yes, that's an indication to get evaluated. Um, if the pain persists for more than a few hours, which you would typically expect after an injury, yes, you should get evaluated. But beyond that, no. If everybody who had a quick involved it started going to a urologist to get evaluated for fertility, that would be wrong. Not really needed.
Yeah, there will be a long line outside the OPD then.
Yeah, every boy has had it. So certainly
I
you can't have
understand. I understand.
it.
And what if there is pain in the testicles, which is not going away without any, known cause?
Yes. So anything which doesn't go away needs medical attention in general. So I wouldn't recommend that you are getting it treated because it's infertility. But if you've had a pain in a groin for a persistent period of time, if you've had a lump for any significant period of time, those need to be evaluated per se. And that doesn't mean that you're evaluated for fertility, but you need to be evaluated in general. And as a part of that evaluation, it may turn out that fertility also needs to be assessed and would get done.
Right.
But don't go to infertility treatment because you've had pain in the testicle. The
Right.
testicular pain in itself, persistent, should be evaluated.
It's very important to know the causes of male infertility. But before I get to the factual ones, I'd like to ask you a few that I came across on social media. And I'd just like you to tell me if there's any real scientific validation behind these things. So if you use a sauna, spend a lot of time in a hot water bath or a sauna, does that reduce your fertility?
So heat beyond a certain level and a persistent recurrent exposure to heat can affect fertility. Therefore, if you're sitting in a sauna every day for an hour or two and then trying to conceive a child, you may be affected. Remember, all these things become relevant only if you truly are infertile. That doesn't mean that everybody who has sauna bath every day will become infertile or has fertile infertility. And these are reverse conditions. So I'm not going to tell you to stop going into sauna every day. If that's what you do every day and you have no fertility concerns, just go and do it. So be it.
Right.
But if you're getting evaluated for infertility and we find recurrent or prolonged exposure to heat in the last few months, then we would recommend you not to have that exposure.
Right.
So it's the other way around. It's not like stop doing sauna so you won't get infertility. That's not what I'm recommending. But if you
Right.
do have fertility,
Right.
then exposure to heat could have been a potential cause. And
Right.
therefore, we would recommend staying away from it, particularly because it's reversible. Stop doing it, oil production should come back low.
There seems to be two opinions about the eating of the flesh of animals when it comes to fertility. In some cultures, they recommend certain things to eat and they say it makes you more fertile. And in some, they believe if you eat non-vegetarian food, then your sperm sort of dies or is it adulterated? Is either of them true?
I have zero knowledge of what you've just asked me. I have no evidence to support a yes answer or a no answer to what you've just said.
But
So
there's
I would
been
just,
no study or
there is no evidence
okay,
whatsoever to support this. I mean, I'm
okay,
sure whatever is your belief works better for you. If it
right.
stresses you out because you're eating non-veg, that stress could cause you to have
Stress
infertility,
response. Yes, that makes
not the
sense.
food.
And what about tight underwear?
Yes, so the tight underwear story is again the same thing as the heat story. Uh, Tight underwear basically push the testes up into the scrotum, and when they're pushed up into the scrotum, they're exposed to a higher degree of temperature. They're actually one of the embryological theories behind why are the testes hanging outside the body is supposed to be that they're supposed to be exposed to lower temperature because sperm production is better at lower temperature. That's the embryological theory of why do they hang outside and not stay inside. So if using a tight underwear, they actually get pushed up into the sacs and the exposure to a higher temperature. Therefore, that could potentially be a cause if you're infertile. And
Right.
again, don't start with those underwears just because they can cause infertility.
Right. And what about age? Because there's a common belief that while women's fertility decreases with age, for men it stays the same. Is that true?
Not really. The as a as a man ages, many of the
Mhm.
hormones will tend to decline. The sperm production over age won't decline. It's just that it doesn't remain relevant in what we call the reproductive age group. A classic reproductive age group, the sperm counts are reasonably consistent, and therefore age for a male within that reproductive age group is not really a concern. But yes, as they become older, the counts are expected to decline over one single. But again, a guy who began with 300 million per ml at the age of 25 is quite unlikely to become extremely low just because he's 60, 70 years of age. It may just depend, but may still be within a fertile range.
Right. And lastly, does size have any bearing on quality of sperm? If you have a bigger penis,
None
do you have
whatsoever.
better sperm? No.
None whatsoever.
Right. Now, if you could tell me what are the known causes of certain disorders. So, okay, I can't even pronounce this. It's called sperm agglutination. Am I saying that right?
Yeah, you're saying it right. Absolutely.
Can you also tell me
All
what
right.
that is?
Yeah, well, sperm agglutination is a condition where the sperm cells clump together in the semen.
Mhm.
That's something so uncommonly investigated and uncommonly treated that we really don't need to bother too much about agglutination in itself.
Mhm.
Um, I'll give you some inside story about fertility, particularly male fertility. Like I said, we have only one test that we really rely on. That's the semen analysis. And even while looking at the semen analysis, we are often at a complete loss. That this guy has a normal set of counts. Everything looks normal. Yet he's unable to father a child. Therefore, how do I explain his infertility? Then we look at a bunch of other tests. Agglutination is one of them. And there are a bunch of other ones. DNA fragmentation. And you find a
Yeah.
number of terms being thrown about.
Mm.
While those tests have a value in a certain specific circumstance, in a general evaluation and practice, they really don't mean much. There
Mhm.
isn't much I'm going to do if a guy's report comes back as agglutinated sperms, other than to say that these need to have an additional procedure before you undergo an IVF. Similarly, if I come back with high DNA fragmentation, I'm just going to require doing some modification for IVF. Therefore, just looking at agglutination alone is really of little relevance, and we don't treat it. We don't
Mhm.
treat that particular condition. We may need to do additional procedures if the person is undergoing an assisted reproduction or IVF. But otherwise, you don't give medications to treat his agglutination.
Right.
Coming back to your question on causes. So we
Mhm.
typically divide them into two types, reversible and irreversible. So when we look at reversible, which is what we're hoping to do, some of them are lifestyle related issues. This is where we go back to that heat exposure goal. So have you been exposed to excessive heat in the last few months? And if you find that as a cause, then yes, that needs to be reversed. So that's a reversible factor. So that could be your sauna, your tight underwear, your laptops, and stuff like that.
Yeah. Yeah.
The second common reversible abnormality we find is people taking drugs. Well, let's say medication, drugs is the wrong word.
Mhm.
So-called medication to treat their fertility, which is actually going to be making them infertile. So many of them are getting hormone supplements. Now, the
Mhm.
hormone supplement could either be to as a bodybuilding part of a supplement, protein supplement as a part of the
Mhm.
bodybuilding thing,
Mhm.
or because they've seen somebody for infertility and the fellow has said, let's give him more testosterone because testosterone makes sperms, feed him tons more of testosterone, they make more sperms.
Yeah.
That actually causes infertility. So the second reversible cause is use of medications, particularly steroids and testosterone, which could suppress fertility. So we'd ask them to stop that. Third reversible cause is again medications, but more like antibiotics or recent exposure to illnesses or antibiotics, which we would just wait for the effects to wear off. The fourth common reversible cause, and this is a part of controversy, is something called a varicocele. It's an abnormality within the veins, within the scrotum. They're very common. They actually occur in 15% of all men and have no consequences whatsoever in the majority of them. But in some have infertility and who do have a clinical varicose, that could be a reversible cause. We could treat that and that could improve their fertility. So these are the and stress, of course. The probably the single most important unmeasurable thing is stress. So these are the reversible causes, which we would look at first. Then you look at irreversible causes. And the irreversible causes include things like sperm production in itself being suppressed because the testes are abnormal. So that can happen because of genetic abnormalities or hormonal abnormalities. They're uncommon, but they can happen. And they are very difficult to reverse. There could be abnormalities such as individuals who received chemotherapy or radiotherapy in childhood because they had cancers of some sort. That could have caused a suppression of sperm production. That's often irreversible. And there are conditions where there are abnormalities in the passages. For example, the vas deferens, which transports sperms, is non existent or blocked. So they will be reversible in the fact that sometimes they can be reconstructed, but very often it's not reversible. So these are the common conditions that we would see, which we would divide them into the reversible and the non-reversible causes and treat
Right.
them as we
Right.
further.
And suppose you find the cause. I've come to your clinic and you've discovered what the cause is. If it's reversible, you just stop doing that thing. Is that as simple as it is?
Right. So the reversible, like I said, the bulk we talked about were lifestyle issues. So the reversible one was stress.
Mhm.
Or whatever you can do to get rid of it would help. The heat exposure, we would certainly stop that. That's reversible. Exogenous steroids, we would stop that. Recent febrile illnesses or antibiotics, we would wait for the effects to wear off. So these are the reversible things. And if we find them, we would certainly address them.
And
But then if
sperm is
you
forgiving in the sense that within a few months you'll be fine again?
Oh, yes. So when we look at reversible patterns, let's say somebody come to me with upper sperm count. Uh, Sperm production is extremely variable, and it could change from being extremely low one day or 1 week to being normal a few weeks down the line. And there is a scientific study to support this, which looked at one man who produced a child, and then they looked at his sample every few weeks over the next 1 year. And I found the sperm counts or numbers changed dramatically from being abnormal to be supernormal. And what that basically means is you don't trust a single value of semen analysis because it's extremely variable. You pick multiple values. The only exception to what I've just said is men who have zero sperms or men who have zero motility. Those are certain conditions which have specific causes and they require specific evaluation. For everybody else, we would, yes, first attempt to address the reversible factors. But if we found that there were additional abnormalities, for example, we found there was a hormonal abnormality as well, we would address these specifics in addition to addressing the reversible factors.
And in terms of, surgical interventions or new medication, is there something already in the market or expected to be around soon that might really help reduce infertility issues?
So when we divide these treatment into two parts, we look at the surgical aspects and the medical aspects of it. Surgery is restricted to a very finite set of patients, a very limited number of patients. So the first set of patients are those where the sperm output is zero. This is the technical condition we call azoospermia. There are no sperms. One of the conditions there is an obstruction. So why does this happen? The testes are producing sperms, but there's a blockage in the pathway somewhere, and they can't get out, which we believe is because of an obstruction. Those are candidates for surgery, and they require microsurgery. So that's one set of patients where surgery would work. The second set of patients where surgery might work are those where we talked about a condition called a varicose. Those are people who have poor counts, and we believe it's because of an abnormality in the veins around the testes, and ligating those veins or treating those veins sometimes helps. That's the second step where surgery would help. Of course, somebody who's had a previous vasectomy and is now infertile would obviously benefit from a microsurgical reconstruction. Other than that, it's usually medication, if medication works, or assisted reproduction. Unfortunately, there is very limited role for medical therapies in male fertility. There's a very small set of patients where medicines will truly help them. Uh, if we do attempt it, we would give the medicines for at most 3 to 6 months, see a response. If there is no response, we would move them on to IVF. So that's
Right.
the spectrum of our treatment for most of.
Right. And IVF is the last option.
Sometimes it's the first option, actually. There are
Oh,
many times you look at a patient and you
mhm.
look at him and you say that there is nothing that can be done for surgery or medical therapy wise, and therefore IVF is the first option.
Right.
And one of the one of the messages we take away from over 20 years of our practice is the best advice a urologist can give to a patient of male infertility is to diagnose him correctly and tell him that I can't do anything for you. What you need is IVF. That is often the best evaluation and the best treatment. To say, this is what is wrong with you. There is nothing I can do surgically or medically, and you need IVF. Don't waste time with random stuff. Go get IVF done. So
Yeah.
that is something we do very often, and that is
Yeah.
probably one
Just
of
be
our biggest
upfront.
roles.
Yeah. Yeah.
Yeah, you have to be upfront. Though. So much you can do.
Yeah. Um, just in terms of general well-being of the male reproductive system, and this includes, urinary hygiene and sexual hygiene and so on. Again, I feel we don't talk about it as much when it comes to men. Um, Not that we talk about it enough when it comes to women also, but there's been a little bit more awareness coming up these days. So, what is, an ideal lifestyle, ideal hygiene practices for, the reproductive well-being of a man?
The answer is going to be very generic here. It's handy, like yourself, typically means living healthy for as you would do for any other thing. One of the
Mhm.
bigger concerns these days is people dealing pregnancies. And that is a bigger issue in terms of fertility, not having regular sleep cycles, stress, intercourse as and when you can have it, but not having a particular knowledge about the reproductive cycle, unable to meet at a time when it is a fertile period for the woman. Those are problems which potentiate fertility issues. So if it's a couple who's dealing with infertility, this is the first lifestyle thing we look at. Are you actually able to eat at a normal time, sleep a normal 6 hours to 8 hours a day? How stressed
Yeah.
are you at work? Are you able to have intercourse where you know the reproductive cycle? Often enough, if you can just sort that out, a significant number of your fertility issues would get sorted out. So that's what I'm telling you.
Yeah. Very quickly, I asked a friend about this, and I said, "Is that something you'd want to know?" And his wife are trying to conceive. And he said, I've been told I should quit smoking. But since pollution is everywhere and I'm breathing this anyways, I don't see any reason to. Um, is Can you talk a little bit about the impact of smoke, tobacco, nicotine, and pollution on male fertility?
Um, so there is undoubtedly a correlation between smoking and fertility. That smoking does affect sperm quality. The evidence isn't really grade A, but there is reasonable, some evidence at least to suggest that smoking does affect fertility. So undoubtedly, we would recommend cessation of smoking. And smoking tobacco, effectively the same thing. So that is undoubtedly a given. And you can't really rationalize it by saying I'm living in Delhi and therefore I'm smoking anyways. Even if you're smoking anyways, 6 cigarettes a day is different from 1 cigarette a day, is different from 60 a day. And there is a quantitative effect to that. So you can't really justify it by the Delhi environment and say, I'm going to smoke anyways. So quitting smoking or tobacco consumption would certainly be a recommendation for the male partner. I'm sure it is for the women as well, although I don't treat women for fertility.
But yeah.
So undoubtedly we would recommend. Yeah.
And very quickly coming to the beginning when, I might be a little presumptuous in this that I certainly find that men shy away from talking about infertility issues or problems with sperm. Certainly not something they would share as much as the number of women they've been with. But then again, that's my experience. You've had a lot more. Do you think that's true? That it's difficult for men to come up and talk about any issues they're facing with their reproductive health?
I'll answer your question in two parts. The first part is your question is absolutely correct. And the example for that is the infertility clinic that I just described. It's virtually impossible for us to find a man who's come to us on his own without the woman having been evaluated and being told, get your partner evaluated. So virtually every male who we see is with us because the woman's been evaluated and the gynecologist or the IVF specialist have told him it's your male partner who has a problem, go see a urologist. That's a, I mean, that's proof if any was needed to say men don't come on their own. They're coming because they've been told to come. The second aspect, and is that there is increasing awareness, fortunately, and therefore we are seeing a few more men coming up at the same time that their partners being evaluated. So it's impossible. I mean, I don't remember the last time I saw a man come up and say, my wife's never been evaluated or my partner's never been evaluated. That hasn't happened. But we see at least both coming up at the same time, and that's increasing.
Yeah.
But there's undoubtedly a difference. They just want to talk about
Yes.
it and they don't believe it's there. So that is absolutely correct.
And it is an emotional um, journey as well once you're diagnosed with infertility. You know, reproduction is part of life, and to be told that you can't do it or you're the reason, you know, your wife can't conceive. And sometimes very horrible things are also said. You know, I met somebody who said that my wife tells me every day now कि मुझे बस एक चीज़ चाहिए थी. I only wanted one thing. I wanted a bachcha, I wanted a baby, and you can't even give me that. And it's almost as if, as a man, you're supposed to provide. And that sort of emotional burden and pressure that's coming. It is part of the entire journey of infertility. And so, if someone is listening who is going through this, is there some words of comfort or motivation you could offer them?
Or again, also was in two parts. Women have lived with this all their lives. Even if the man was the contributory factor, women have suffered the consequences to all the ages that we are aware of. Men would marry 5 times before they realize that it's they who are for it and not their partner. So it's time they stood up and be accountable for being responsible for at least half of fertility. At the same time, that doesn't mean that they have to suffer. Because the answer that I have for everyone is virtually everyone can have a child. It's IVF, assisted reproduction, has become so advanced that it is almost everyone can have a child. You just have to give up that concept that I will have it through spontaneous conception only. If you're willing to get over that barrier and are willing to seek help, virtually everyone, there's such a small proportion that's left today that can't have a child, that I would say that there is hope now for everyone. So while it does become a virtue the first time you realize there's a problem, you have to get over it and get treated because it can be treated. And there are solutions
Yes.
today for virtually everything.
Yeah. So the same person whose wife was sort of giving him a lot of emotional pain, I asked him, "How did you get over it?" He said, "It helps me to know that it's not just human men who have infertility. You know, it's not just me. I could have been born a cow or a pig or a chicken, and the same issues happen there. So, I suppose that's also comfort for some. But
Absolutely. So, reproduction is one of the principal reasons why life exists, life exists, and it affects every species. And humans have certainly made so much. And remember, IVF came from animals. It didn't start in humans. It was first used and done in animals, and then came into humans. But it's made so much advanced today that what we was infertility is now subfertility. You need help. You can still have a child.
yes,
And therefore,
yeah.
much brighter today than it was 10 years ago.
And to get that help, you need to have the knowledge. So thank you so much for sharing yours with us. Thank you.
You're most welcome. Thank you so much.
I hope you enjoyed this episode, and we'll be continuing to do episodes with doctors at AIIMS. I'm incredibly happy about this because it's like attending a medical seminar every time, and you learn so much. And there's no one better than explaining things than an AIIMS doctor. So if there's any topic you'd like to know more about or any questions that you have, please do write to us. We are available at pods@indiatoday.com and on 8588966996. And I actually remember the first time I had to say that number, and it hit me like a ton of bricks that I'm anchoring something. I'm a print journalist, and suddenly I'm on air. And really, the person we have to thank for is, and I have to thank, is our producer and our Priya Darshini, who this is her last episode with us. And after 76 episodes, she'll be leaving. And I'm going to miss logging on and saying hi, Anna, which is quite a fun thing to do once in a while. And if there's any relevance or any value that this podcast series has given you, it's genuinely because of her work. And she's been editing, coordinating, and also stopping me from talking your ears off. So thank you.